Older generations. That's what we're talking about. New challenges to live into a healthy old age are emerging constantly. What does it take? What age is even considered old? Public health meeting the challenges of aging? What has worked? What hasn't? And where do we go from here? Looking forward to hearing our moderator, Bence, who is a former director, a former president of the Minnesota Public Health Association, along with Joe Gaugler, Cathy, McLeer, and Adam Suomala. Thank you very much for being here, Ken.
Thank you, Antonia. You on your tables is a list of ancestral statements. So that's there, you can look at that. So great to see you here this morning. I'm glad to be here. I'm always pleased to get asked to moderate these forums. They're always very well put together and we learn a lot from the panelists. Although when I saw what the topic was this morning on older generations, I had to pause for a minute and say, is that a hint? You know, I picture myself, I feel internally, and I picture myself as I was in my 20s and 30s. And I look in the mirror. And you know, when you look in the mirror, it can be dangerous. When I compare, I see that I'm a little rounder, maybe a lot rounder than I was back then. My hair is curlier. It's actually a little bit, used to be a lot darker than it is now. I have more wrinkles than I used to have. Good to have a fan club here. But also coming along with that though, when I look at myself now, compared to back then, you know, back then I had less experience, less knowledge, maybe less wisdom, certainly less maturity than I have now. And so there's two sides to the coin of getting older. As Antonia said, this is a timely topic. What is older? What do we consider old? Did you know that May is Older Americans Month? We're already halfway through, and so this is a very timely topic for that reason. But is getting older, is it an age? Is it a state of mind? Is it a physical condition? I was thinking that, you know, those who I looked up to earlier in my career in public health, public safety, they're now either retired or retiring. And I know several people my own age who are already retired from their primary careers and are moving on to new ventures, often doing more exciting things and things that they hadn't been able to do before. So today, we're going to examine what we know, what we don't know. Hopefully we'll bust some myths along the way, as the title suggests. You can see we have a great panel here to talk about this issue of the older generations and getting older. On your tables is, on the sheets that are there, there's a QR code you can scan to see their full bios, but just some highlights. We've got to my far right, Joe Gaugler, and all of us have connections with the University of Minnesota in common with that going throughout the group today. So Joe is actually on faculty in the School of Public Health, has some very impressive titles. He's the Robert L. Kane Endowed Chair in Long-Term Care and Aging. Anybody who's associated with Bob Kane obviously is a good person. He's an distinguished McKnight University professor, and he's director of the Center for Healthy Aging and Innovation. So we have a lot to learn there. Next, we have Cathy McLeer. Cathy is state director for AARP. I'm proud to say I'm a card-carrying member of AARP. I was looking at the AARP website last night, and some of the things that jumped out at me just on their homepage. You can learn about help for caregivers and balancing work and life, help with Medicare enrollment, when to retire. You can save on hearing aids, even have coupons. How do you stretch before a workout? News, in quotes, about the Golden Bachelorette. And there's information about romance scams. And that kind of is sort of our our image of aging in microcosm. So I'm sure we'll touch on some of those issues today. And finally, we have Adam Suomala. Adam serves as the president and executive director of the Minnesota Leadership on Aging. They're a collaborative of 32 nonprofit organizations. And so they've got obviously a lot of connections in the community when it comes to organizations that touch on aging, including Cathy's organization at AARP, the Alzheimer's Association represented by my friend Robert Freeman, and the area agencies on aging and trellis. Dawn Simonson is the representative, and she's been on the panel here before that I moderated, so that's a good connection. My friend Heidi Holsky at the Gerontological Association, and then the Volunteers of America, represented by Julie Warren, who worked with my career organization. So in my career right now, I'm working in the disability services arena, and disability services are often linked with aging services. Is that a good linkage? Do we consider people that are aging as being disabled? I think that's something we should explore a little bit today. So at this point, I'm going to turn over to the panel, and we can start with Adam and just go down the table. You each get 5 to 7 minutes to speak about topics of your choice, and then we'll come back and have a conversation.
Thank you, Ken. Good morning, everybody. Good morning. Okay, I'm up in the back. Okay. Well, good morning, everybody. My name is Adam Suomala. It's a pleasure to be with you. And to Ken's sort of early question, I think let's jump right in. Let's talk about what is aging. I think often. Let me back up. I think Minnesota is a state of problem solvers. I really appreciate that public health ethics. I think that when we see something that isn't working, we dig in, and how we approach aging is important. So a conversation about this, active, engaged conversation about this, just what we're living longer, healthier lives. But one of the things that I'm sure you all will encounter is that the people that we interact with hold pretty deeply negative views about aging. We hear folks go to great lengths to avoid conversations about aging, about this today. Research shows that we don't even identify ourselves as aging, even in our last 2 or 3 decades. We use terms about how we're serving older adults. We hear conversations around, othering language. We rarely say that we're growing. We rarely use terms like we or us when we talk about aging. Why is that? So what is aging? Aging is often discussed as a process of decline, sort of that loss of support. We talk about it as something that we should be anti-aging. What is anti-aging? Death. That's for that. It pushes down one of the most remarkable transformations of our time, which is that over the last century, scientific and medical advances have extended the average life expectancy by 2 to 3 decades. That's awesome. But so what is aging? It's a more complex answer than maybe folks generally think. It's multidimensional. It involves our physical bodies, our psychology, our spiritual self, our social role, and it changes over time. Right? We tend to think about it as a term of decline, and there are times where the process may be lost, but it's also a time of growth and development. We have this really decline-based narrative of aging and what it means to grow old, to be old. We tend to talk about the losses, but we never really contextualize all of those pieces of growth and learning and development. I was at a party recently, and the question was, you could go back to being 18, would you? And the catch is obviously it's not just you're getting back into your 18-year-old body, it's if you have to go back to your 18-year-old self. And not one person around that table would be willing to sacrifice those lessons learned, those growth and developments that we get. So on some level, we value it. But then why do we have such a negative connotation to it all throughout society? Unfortunately, the way we talk about it has generally led to a collective inaction on the policy. Minnesota is often hailed as the greatest state to grow old in, and I am a very proud Minnesotan. But about aging, we see that even in our state, policies and practices for this age, it's not good for anyone, not good for our family or our friends. It's not good for us, if we're being honest. So we need your help changing that. Public health, I think, is really on the front lines of that conversation. And we need you now in a way that, actively ask that you continue this conversation after today. A couple things to consider. First, words matter. I'd like to start by sort of understanding the language we use when we talk about it. Researchers find that there are terms that are more productive than others. So if anyone uses the word elderly, please stop using it. Senior citizen, they, for most folks, connote these conversations about, fragility and technological illiteracy. That's not where we fit. We also see terms like, aging sector, older people is a term, but folks or older adults is a term that people tend to think of that term as research shows us that older person, that tends to be sort of the image, a more realistic image of people over 67. I would also say a call for justice beats a call for sympathy. Values are this cultural elements that help us understand why issues matter. And in controlled testing, we see the value of justice, this idea that our society should treat all people equitably. It's particularly effective at orienting people to aging at the systemic level. So, if I sat down, I was at Joe's legislative task force on aging. If the first words out of my mouth are Minnesota seniors, blah, 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 I've instantly created an othering of older adults. I've instantly used a word that's polarizing or has some baggage to it. But if I sit down and I say, as we age, blah, 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 I'm using inclusive language. I'm connecting myself to this experience of aging. I'm not putting up a wall. So the language we use, how we start framing it, really matters. So, if I ask each person in the room, if somebody labeled old, what would go through your mind? And, I work at the Minnesota Leadership Council, so theoretically, I would know better. But the reality is, and we'll talk more about ages, I hope, but this is fully baked into our tradition. It's really hard to bust out, just like those other, it's hard to unpack. But if we live in a culture that values youth, which we do, and directs us that aging should be feared or battled against, we're going to be afraid of getting older. We're not going to envision a later life that's more powerful. And that internalized aging, then funding and perpetuating sort of that externalized. And you'll start to see this you'll see it in family functions, see it at every stand-up comedy routine ever made. Advertisements, magazines, unabashed, unapologetic, aware aging. And we can be on the front lines of achieving that. So I'm happy to be here today and happy to have you.
Well, good morning, everyone. I'm Cathy McLeer, the state director for 8 Year in Minnesota. I sort of feel like aging needs a tagline, right? Get old, everybody's doing it. I looked to see if this was trademarked, and apparently the Ohio State University. I'm a urban grad, so I don't know how much I want to put that, but Ohio State did it in 2018. Aging, it's so cool, everyone's doing it. And kudos to Adam for the work he's done with the Minnesota Leadership Coach Council on Aging. Sorry, I was so that. I'm a delegate, I should know better. On the work he's done on reframe aging and bringing that initiative to Minnesota, really increasing awareness for that. Yeah, it's not new. We are all aging every day, but the way we are aging is changing. Certainly, having said it, we're living longer, healthier, more productive lives. People are working longer, some because they choose to, some because they need to. AARP has changed in the last 60 years. We used to be the American Association for Retired Persons. We are not, because we know at the age of 55, which was the original age to join, now you can join at 50. But here's the best country, right? We actually told you to do 50 and join. I just practice. But people are no longer retired at 50 or 55, so we changed our name to AARP. We are just AARP. So those things are all new, right? That's all changed. But as Adam said, what hasn't changed really are those attitudes and stereotypes about aging. Think about how many 50th birthday parties we've been to with black balloons, over the hill birthday cards. I actually heard there's a Minnesota woman who is trying to disrupt the greeting card industry by making 50th birthday cards that celebrate aging, rather than saying you're over the hill, you're past your prime. I now have friends with kids who are getting married or younger friends who, their 40th birthdays, they're saying they're over the hill. I'm like, what? No, we're not. Not yet. So all of those stereotypes are just really out of date, and many of the solutions that have been available to us are also out of date. So we have to change the conversation about aging. Aging is about growth. It's not about decline. It's not just about the challenges that we experience as we age, but really that older people are contributors, not burdens. We need to involve people as they are aging. As I said earlier, it's about being wiser. It's about having experience and life experience, lived experience that can really contribute in a very positive and significant way. We should all be valued for who we are, not how old we are. And ageism can really run the spectrum, right? It's not just older individuals who experience ageism. As a young person in the broadcasting field, I experienced ageism because it didn't look professional enough. It didn't sound professional enough. I actually had a professor at the University of Minnesota who told me my voice was too high and I didn't start drinking bourbon and smoking cigarettes on one end of the television. Probably not the best advice to a young aspiring journalist. So ageism really can be at all ends of the spectrum, right? But we should be valued for who we are, not how old we are. And AARP's vision is really to create a society in which everyone can age with dignity and purpose. Our state is getting older. Estimates are by 2030, about 20% of the population will be 65 plus. But we're also getting more diverse. And we know that aging well and aging with dignity and purpose can mean different things in different cultures. And so as we age as a community, as we age as a state, as we become more diverse, we have to be more inclusive of combating ageism across cultures and across diverse populations. So I think we have a lot of opportunities. I'm glad we're having this conversation today. I'm really good company and very happy to be these very knowledgeable folks. And I appreciate being here.
Well, thank you so much. And I so respect the work of Cathy and Adam. It's both two tough acts to follow. Addressed a lot of the points I was. I don't think it's new to anyone here. We're in pollination of Minnesota. There are more older people now in Minnesota, I believe, are the people here. And I think that is the case, not sort of, and a term that's been used to describe this, quite frankly, by people that are both in our government, to some extent academia, is this idea of aging tsunami. We are in a tsunami. What are we going to do? It is a crisis. So what is a tsunami? It's a catastrophic event that often results in mass casualties. I mean, I don't quite think that is the case here. So, I mean, this really follows on what Adam was talking about, which is, yes, there certainly are challenges, given that we are in society. But at the same time, there are opportunities. What are those opportunities? It's that latter aspect of us living in this aging society that I don't think necessarily have to thought about. Now, does anyone know why we had this remarkable longevity in the US? Any idea why? Yeah. Thank you for saying that. 75% of, and this is actually from really one of the great geriatric scientists in the US, Reed, at Columbia University. He gave a wonderful presentation. So 25% of this public health innovation, like decreased infant and child mortality, and prenatal and care, better nutrition. So very much healthy aging is a public health issue. It is a scope of public health. Now, one thing I will challenge you is, as public health as a discipline and profession, has it addressed aging as effectively as it could? When you look at many departments of health across the U.S., are issues like dementia, other aspects of aging, are they necessarily public health priority? I would argue that that is a important issue for us to think about. Is aging itself is a public health issue? I think the discipline of public health is very well positioned to address this. What are some of these opportunities on the leading? How do we redesign what is essentially a stage of life? Again, ARP has done a lot of great work leading this area. But thinking about employment across, how should it look different? Expanding volunteering. Rethinking how and where we live. I think many of us can say with some degree of confidence, the current model of residential long-term care probably is not going to be. It's been plagued by certain issues or chronic for many years. It was mentioned Dr. Kane, he was a mentor of mine in college. And my office was real. And I went through some of his whole conferences, so I just get a sense of what this legacy meant. I remember he had some memos from the late 90s, 2000, about various challenges for residential long-term care staff, how we regulate, etc. They haven't changed. So, we're at a point probably where thinking of radically how we residential long-term care. Again, I think it's an opportunity, maybe now where these significant changes have. Healthcare redesign is another opportunity. There are some policy innovations that time about, but thinking about how to provide people needs to go beyond a patient to a family, caregiver folks. Certainly know the best way to care for people, considering care, not just parent services. Too often, the healthcare is incentivized, but services delivered to a person. That's not sufficient in many instances. Environmental redesign is also a opportunity, and spray air policy provide some state. How do we make Minnesota? And on top of that, there are friendly communities. Even a friendly person can this last point, maybe this is more of an issue for me, but I think I need to discuss it, which is moving beyond the biomedical lens of aging and thinking of it. Certainly, I see my colleague, Dr. McLeer, nursing, it wants that program that way, certainly public health does. But when you look at the university, and you look at many academic institutions across the US, where are the centers of aging? And this inherent belief, whether it's conscious or not, thinking of aging and aging as a time that is said, then built into some certain and heard at the art pieces medical school line anti-aging campaign, anti-aging, which I trying to be, saying, because if we really think about it, I mean, how has aging treated health for us? I mean, when we think of, for example, this workplace. Where many other people just housed together. Number of other times, thinking that you're older, it is the need. So there are historical roots, and when we look at the ages, which again is certainly the one could argue at the book. That's really what I think about when I consider the design. You know, maybe aging, not just as a challenge, which again certainly can be some. It's I really do think. Have to think of aging now.
Great, thank you all. Appreciate how all those perspectives kind of fit together into common themes and really illustrated kind of the overlap of the kinds of things that you're talking about and things you do. So let's have a little bit of a conversation and explore some of these ideas. The theme of public health certainly is coming through here, and how public health approach to helping people through the aging process can be a helpful thing. And we've talked about how through public health we've extended people's lives, and yet the healthcare system hasn't kept up. And so we're not doing what we can do to maintain people's health as they age. And so I'm curious, from your perspective, Joe, at the university, what connections does what you do have with the medical school, for example, to explore some of those care issues?
So one of the, you know, I think one of the great tragedies of the university scholarship practice was the decision made to shut down. Okay, I'm trying. I can yell. You know,
I have to follow your mouth as you turn your head.
Can you hear me now? So again, what I was saying was one of the great tragedies at the University of Minnesota as it relates to aging science and care was the fact that the Department of Geriatrics was shut down in 1999. It was a very good small department, but they did a lot of innovative work in care models, services, and supports. And I really do feel like even though there's been fairly robust scholarship and applied research in aging and basic science, that clinical link in aging was missing. And that actually can operate to bring everyone together effectively to really pursue, again, some of these challenges and opportunities. Now, a new division of geriatrics has been launched. That just occurred a couple of years ago. However, there still needs to be a search for a new division director. Probably there'll need to be more geriatricians brought on backward for that to have success. I think of our links with the medical school, for example, largely through the work of people like Dr. Jim Papala. He directs something called the Geriatric Workforce Enhancement Program, which I'm involved in leadership capacity, as is the School of Nursing with Dr. Chris Valley. And what's exciting about that and the GLEC program is it really focuses on how can we provide interprofessional education and training as it relates to geriatrics. And this extends not just to professionals, but also extends to community, families, other people heavily involved in care. That's one example where I can think of where the med school, public health, but quite frankly, many other entities collaborate together to again address key issues as it relates to age. A big emphasis of GWEB has been age-friendly hospitals, healthcare systems, working with healthcare systems. That's both.
Cathy and Adam, how does the concept of healthcare and supporting people who work in the aging process impact the work that you do?
Well, I think certainly in this country, our healthcare delivery system is so reactive, right? We treat disease we treat conditions, but we're not very good at preventing. And so I think if we can, on the front end, keep people healthy so that they don't experience the issues to go, that can improve our lives going forward. Thinking about some of the age-friendly work and different things that AARP does to keep people healthy and aging well, keeping them engaged and active. We just launched this year a Walk with a Doc program that invites people to join with a local physician, have a little conversation about healthy lifestyles, and then just simply go for a walk. Giving people access to those kinds of things. For our 60th anniversary, we put an outdoor fitness park in every state across the country. Ours here in Minnesota is in the Rondo community at the Ground. It's a great outdoor fitness park that everyone has access to. We know that it is, it's expensive to join a gym. And you don't have to, put your sweat on for 2 hours a day to be healthy, but you just have to move a little bit, and giving people those opportunities to go for a walk with a physician that can provide some advice. Have access to a fitness facility in your neighborhood. Opportunities for social engagement and meaningful connections. We saw during the pandemic, and maybe we'll talk about this too, but social isolation just became such a devastating problem. Being able to have those meaningful connections in communities. When we talk about the age-friendly work, and he is the WHO's North American partner in age-friendly communities. When we talk about the domains of age-friendly, a big part of it is social connections and inclusions. Having people involved in the conversation, nothing about me without me, right? So keeping people involved in the conversation about what they want their communities to look like, making sure they have access to affordable, appropriate, accessible housing, transportation options. Certainly when you think about rural Minnesota, greater Minnesota, if you have to drive 75 miles or 150 miles to get to a grocery store or pharmacy, that's really problematic, right? So making sure that we have that infrastructure in place in order for people to access the services they need and have those meaningful connections in their communities so that they continue to have that purpose as they need.
For me, what came to mind was programs like Juniper that offer evidence-based health and wellness classes, programs like Matter of Balance to help us with fall reduction, diabetes prevention, resources around sleep. I would also say that there's this interesting crosswalk now around technology that we haven't really touched on, but helping people stay independent and healthier through monitoring vitals, different ways of automating things, cleaning robots, medication dispensing. My buddy Joel Prevo just had his mom move into the house and she can't comfortably adjust the blinds in her room. So in a very inexpensive way, he helped hook up an Alexa product that allows her with voice commands to lower her shades. We're living in the Jetsons future. People like this is there are opportunities that I think are there. Also on the health front, I think back to another Minnesotan, Dan Buchner, with Blue Zones work, and there's just some really practical things in there, even for us as individuals. Around a little further away at the grocery store, move your body every day naturally. Take the stairs. I was telling Julia Wolf earlier that I kind of hooked on Julia Louis-Dreyfus's podcast, Wiser Than, where she interviews wise older women. And her first guest was Jane Fonda, and they said, what advice do you have around aging? Jane Fonda said, stay strong, build up your body because you're going to need it to be in that strong position going forward. But those things like reflecting on our purpose, or there's a great conversation right now happening around stress. Dan would call it downshifting. This idea that stress leads to chronic inflammation, linked to a variety of diseases. So whether that's having a daily meditation practice, prayer, going to a happy hour, there are things we can do to impact health, which you all know. But I think there's something embedded in that. And then the last comment I would share is this idea of belonging, finding our tribe, family, friends, that connection that Cathy was talking about to community, social networks, the impact on our health of those activities cannot be understated.
So to talk about healthcare and overlook talking about COVID-19 and the impact that has, particularly on people who are aging. Cathy mentioned isolation, that certainly was an issue. We know that people who were older were impacted more by the COVID virus, and mortality was higher. Cathy, I'm curious, having come through that whole pandemic, has that impacted the work that AAR does?
Certainly, we really had a renewed focus on combating social isolation. Seeing long-term care facilities that were locked down, people see their families, they were afraid to go out of the home. I mean, it really is a problem. We launched a Friendly Voices campaign so that people could receive a simple phone call from someone just to have a conversation so that they had someone to connect with. Another thing that came out of COVID-19, we had been for a number of years seeing a decline in hunger among older persons. And just in the last couple of years, we've seen about a 25% increase in hunger among older populations. One good thing that came out of it was I think people recognized what resources there were in the community, and it helped to, in some cases, destigmatize the need to tap into those resources. But now that some of that COVID assistance has gone away, some of those resources are starting to decline, but the need is no less. So yeah, social isolation, I think some of the hunger issues, certainly as Adam said, it lifted the importance of technology and having access to technology, telehealth, hospital at home, having access to broadband infrastructure. But there's a negative side to that too, that there's lack of access in some areas. But if you have it and you can't afford to tap into it, the Affordable Connectivity Program just ran out of money. For people who were able to stay connected with their family, able to do telehealth visits, they may not be able to afford their internet. And then there's the whole digital literacy. So, we know our membership spectrum, right? I'm 51. I'm part of the generation that did not have technology, and now we do, and I've embraced it. But, my mother, who is 78, every single doctor requires an online login to access your records and to communicate. That's a challenge. It's a real challenge. And so while I think the pandemic really heightened the awareness and the benefits for technology, it also raised the profile that there are some real challenges on that too, and we need to support technology.
Adam and Joe, how have you seen coming through the pandemic and the work that you do?
So I just want to, when I think back, so I started at the Minnesota Leadership Council in April of 2020, right? We're in lockdown. Joe's a delegate, Cathy's coming on board. Like we're trying to figure out what this new world looks like. To the degree that we can use this as a case study to understand the crosswalk of public health and aging through the pandemic, some observations I would have. In that first 6 months, we knew that older adults were as you said, just disproportionately. On July 8th, I remember we had a day of remembrance. And at that point, Minnesota had 1,477 deaths due to COVID. 78% of those deaths, that's 1,157 people, were in our long-term care or assisted living setting. And the response from leadership across the state was largely complacent. It was an acceptance that older deaths are somehow okay. And the focus on children and schools was front and center in the news, front and center from the Department of Health all the way down to media. And where was the conversation about where 78% of the deaths were occurring? It was not there. And so I just think we should really be very transparent and open about the conversation around why was that? I would argue that it's ageism. But I think that as we look at how do we build a system that can respond effectively in those moments, let's use this as a real learning opportunity, because that can't happen. I would also say from an equity standpoint, when we were looking at vaccinations, and some of you really know this as well from your day-to-day work, you know, there was this big box, white majority approach to vaccination, you know, and, you know, we want to do a clinic, but you need 500 people. Well, a Black nurse working in a church doing vaccinations, people she knows, has an ability to get that work done versus telling everybody, you need to go to the Mall of America, stand in the line. Don't worry, we're here from the government to help. It was not successful. We were so focused on majority numbers, and all of those cultural communities did not get access to the services that they needed. And what happens in that moment? Disparity gaps continue. We could have, should have done better. And I really hope we step back and really put sort of the autopsy without blame on that from an equity standpoint. There's been a lot of lessons to that.
Yeah, thank you, both of you. I don't know if I have that much something to add. I think, as was alluded to, I mean, COVID-19 was really this tragic natural experiment. First and foremost, as it relates to social isolation. I know we had a study going on at the time where we were providing a support program for families who care for loved ones who are cognitively impaired who live in residential homes. And so in a way, our study pivoted to really focus on the effects of COVID-19, the support we were providing. You would hear terms used by families and staff of like failure to thrive in your loved one because they were literally cut off from any social. And again, it emphasized why social connection, social well-being is so critical to health engagement. That oftentimes is overlooked. It's seen as this soft, fluffy dimension, and it's not related to the medical care, et cetera. Clearly, COVID-19 demonstrated. I think another thing COVID-19 emphasized very strongly, and again, somewhat tragically, was we continue to approach care for older people in the U.S. in a very siloed fashion. Why I say that is we also have the national study of adult day services that was going on right in this pandemic. Many states, including Minnesota, simply shut their adult day services down because they were deemed quote unquote non-essential. When you talk to families who were using those programs for their older relatives, particularly those living with dementia, they were certainly not non-essential. So understanding again this idea of good care for older people is integrated care. It's integration across chronic as well as acute/hospital-based care is really what we should always aspire to. In what COVID-19 showed is if you don't have an integrated model, the gaps and disparities that then emerge. I think the last point I'll make is also, and this is for public health aging significantly, is the idea of understanding social determinants of health and how they contribute to aging. One of the most interesting findings to me that came out of the COVID-19 pandemic was when looking at nursing homes that had the highest COVID-19 rates, the one factor that drove the highest rates wasn't necessarily issues going on within the nursing home. It was really whether a nursing home was in a county or area that had a high COVID-19. And so again, what it suggests is, it seems fairly straightforward, what it suggests again, how even though we seem to think of nursing homes and care for older people as kind of this siloed entity, it very much is reliance on community around social determinants of health. And so understanding that effectively moving ahead is going to is important for us with aging and particularly health.
So my work in the disability services world and your work with people who are aging, people who are in those categories and are living in long-term care congregate settings or home and community-based settings, they're being supported day to day by usually entry-level people who are their caregivers for the most part. We know that there's a huge workforce crisis when it comes to those caregivers. What thoughts do you have, and anyone can start on this conversation, what thoughts do you have about how we can deal with this workforce crisis? Because better, we're seeing fewer people entering the workforce. Thoughts on that?
Yeah, thank you. So. Yeah, this one is this is a challenge. I think Adam probably, obviously will probably have better insight than I would workforce. You know, I think a lot of the discussion around workforce issues in long-term care has focused on how can you create a career pathway that is seen as something valuable to the people engaged in the work, that there actually is a long-term path in that given career. And traditionally, that hasn't always been the case. It's really for director workers in nursing homes. So this is such a conundrum, such a difficult problem, right? There have been a number of solutions tried. I am by no means an expert in workforce issues, particularly in residential long-term. That to me seems to be a core issue is, do people who enter this particular job, or in many communities, let's be blunt, working at the local fast food will make more money than a direct care worker. Now salaries and everything. One way we have to probably view the workforce and direct care workers in particular is that how can we create career scouting for these that is effective. Again, many ideas out there, whether they do be effective. Again, I think we keep coming back to this idea of context, public health context. I think the residential long-term care, we would be remiss if we didn't also understand how our residential long-term care settings often finance. We have seen, for example, venture capital, just like they have with hospitals, moving into the residential long-term care industry. Does that have particular implications for how staff are paid, how many staff are hired, retention, et cetera? And honestly, when one looks at the research, it doesn't paint a very rosy picture. So understanding the context is important. Well, try to tackle the long-term care. I'll turn over to Adam, but I think Adam.
Yeah, Adam, really briefly, anything to add?
So I've been thinking about this since the year 2000, because I had our conversation with our then and Malcolm that here's the
Former
demographic.
president.
I'm a big fan. She's the one who got me into the aging sector, so I think that. First of all, I would just say this is a demographic issue. It's also an issue of sexism and racism in our state. There is no silver bullet to solve this problem. And I put a lot of emphasis on a lack of leadership with Minnesota legislators. And at the end of the day, so much comes back to the reimbursement rates and the chronic underfunding of the aging sector. And that is an indictment, not just of the old administration or current state and House and Senate leadership, but my 25 years watching this unfold, nobody has provided a priority on aging issues in the legislature, and it's time for that to change. So we see this creation of a children's cabinet and a Department of Children, Youth, and Families. At the same time, we see the elimination of aging. We see great progress made for like student meal programs in schools. At the same time, the senior nutrition program didn't get an increase in their rates for 20 years. Why is there not leadership across the lifespan? Why do values apply on one end of the lifespan but not on the other? Let's hold folks accountable. If you want to make an impact on the healthcare, aging services workforce, if you want to make an impact on closing equity gaps in the state, don't do it on the backs of what tend to be poor women caring for old poor women in our state. This is an opportunity for us to, a rate increase, a $25 livable family sustaining wage in the aging services workforce would literally lift families out of poverty in our state. 80% of that workforce in the Twin Cities metro area are people of color. We want to make a difference. We can do that, and we have to ask our lawmakers to. So I don't think there's a silver bullet. I don't think there's a one solution. I think there's recruitment issues, retention issues, recognition issues, culture issues. There's a bunch of things that we can do. But Joe said, we have more people in our state that are over age 65. I would never put children against older adults, but I do think that we need to do better. We need to elevate aging as a public priority in the state. We have to have elected officials and state agency leaders held accountable for leadership across the landscape.
Really, really quickly.
So thank you. I'm always impressed by how passionate Adam is about this. So thank you for that. I just wanted to circle back to a couple things that Joe talked about too, is making those, well, two things, right? A long-term care skilled nursing facility will always be necessary on some level, right? But our research shows over and over and over again that individuals want to age in their home and community. So it's not just the long-term care workforce we need to be thinking about, it's also those who are providing home and community-based services, okay? Also, the pandemic showed us that, as Bill also said, the higher instances of COVID you found in nursing homes was because it was higher instance in the community. That's because long-term care workers didn't have sick and safe time. They didn't have the ability to stay home if they were sick. Also, when you talk about wages, yes, it's a little bit about wages, but it's also making sure that those workers have an opportunity to save for their future financial security, making sure they have opportunities to save for retirement, that they have benefits, that they have health care. AERP was a strong advocate for that, for making sure that long-term care workers have the opportunity to take the time off they needed to care for themselves or their families and not come to work sick and be detrimental to individuals. So hopefully that's a segue to the next conversation about home and community-based services and ways that we can serve the population better.
We're at the point of the program where all of you get to add to the conversation. So we invite you to have discussions among your tables or other groupings. There are cards or post-its at your tables. We invite you to write down questions and pass them to the committee, which then we'll look at getting to as many as we can with the panel. So we'll reconvene in about 10 minutes. Thanks.